Hello, I'm Dr. John Cruz, and today I'm going to be talking about Amantadine for ADHD. As usual, I'm going to start with a take-home message. I'll be talking probably 20-25 minutes. This video may wind up being substantially longer if there are lots of questions at the end of it, but the presentation parts will definitely be under 25 minutes today. And if you don't get your questions in now, if you type them in later, I do come back and respond to comments on these videos. So the take-home message is that Amantadine is an agent that's been used widely for at least 50 years for Parkinson's disease. It's used in Parkinson's because it was claimed to be or promoted as a dopamine-releasing, increasing dopamine availability agent. And that makes it a logical choice to use for brain that promotes the release of norepinephrine as well as dopamine, which makes it an even probably better choice. And on many neurochemical ADHD experts' lists, it's in the third tier choice of drugs for treating ADHD. So stimulants being the first tier, non-stimulants that are FDA approved, such as Intuniv, which is guanfacine, and atomoxetine, Strattera being the second tier, and then other agents are sort of lumped as a third tier. There are only, it's 4 or 5 studies that have been done. All of them are in children and with ADHD, all of them suggesting positive effects of Amantadine for treating ADHD. And it's encouraging because it seems to help with a range of impulsivity, focus, and aggression. So a pretty broad range of ADHD symptomatology and fairly mild, low side effect profile, particularly compared to the stimulants and some of the other non-stimulant options. So the take home is that for many people, it may be a reasonable agent to try, although right now it's not at the first tier. So jumping into the heart of it, the FDA actually approved Amantadine first for treating influenza A. So this is a drug that showed up first as an antiviral medication. It was a good treatment in the early days in the 60s for treating what was called Asian flu. There are varieties of influenza A. In the current era, it is not recommended for the treatment of influenza A because so many strains seem to have developed tolerance to it. So this drug was being used by a woman for treating her influenza infection, and she noted that it helped markedly with her Parkinson's symptoms and told her doctor, who was astute enough to, good enough to listen carefully to her and follow up on it. So, with a little more research, in 1973, the US FDA approved Amantadine for treating Parkinson's disease, and for Parkinson's, we know that it decreases bradykinesia, which is the slow movements of Parkinson's. It decreases the rigidity, which is another hallmark of Parkinson's, and it decreases tremor symptoms. Resting tremor is part of Parkinson's. So Amantadine is quite a helpful agent. Usually it is not the first tier agent in Parkinson's. Usually L-DOPA is. And it's very frequently combined with L-DOPA and seems to enhance the efficacy of L-DOPA as a treatment for Parkinson's. It's also being used with increasing frequency for a couple other conditions. One is for traumatic brain injury, and as well as neurodegenerative diseases, including dementias, and we talked about dementias in one of the more recent videos here. It's also been used experimentally for treating fatigue and multiple sclerosis. And it's being fairly widely used, particularly in pediatric mental health clinics for treating ADHD, although again, there's actually very little that's actually been published. So when I was in medical school and training, the claim was Amantadine was just a drug that boosted dopamine release and boosted dopamine levels, may have some dopamine reuptake. And that's why it was a good match for Parkinson's. It's still often listed in many neurology and old psychiatry textbooks or pamphlets as a dopamine boosting drug, which it does have some effect there. But the story is clearly, again, it's clearly more complicated if it's doing just dopamine boosting, since it's already, we know it's an influenza, it's an effective agent in treating influenza A, or was. And then around the 80s and late 80s, early 90s, much of the 90s, there was emphasis on how amantadine affects the NMDA, which is one of the glutamate, the most common excitatory neurotransmitter in the brain, and that this was an NMDA receptor blocker. So one of my other talks recently was also about, in part, NMDA blockers, and one that we have, a prominent one, is memantine. Memantine is actually chemically a derivative of amantadine. Memantine, though, actually does seem to be genuinely a good, robust NMDA glutamate receptor blocker. And although there was lots of papers you can still read that push that the major action of amantadine is NMDA receptor blockade, more recent studies actually question that significantly. And the gist of it is that, yes, there is some action on NMDA receptors blocking them, but it appears that you need considerably higher concentrations than are generally achieved with therapeutic levels. And the amantadine has several other neurochemical actions that are considerably more potent than its NMDA blockade action. So it's not that NMDA may have nothing to do with it, but it's probably a minor role in its help both with Parkinson's and with ADHD. So it's one of the things we know is that when we do blockade NMDA receptors, that it tends to increase midbrain dopamine nerve firing and release of dopamine. So blocking glutamate receptors is one way of boosting dopamine within the brain. So part of what's hard to actually be completely sure of, so like many drugs, amantadine needs to be transported across the blood-brain barrier from the blood into the cerebrospinal fluid. Levels in cerebrospinal fluid tend to be slightly lower than blood levels, not hugely lower. But we also know that levels within brain cells are considerably higher than CSF or blood plasma levels, because amantadine gets transported into cells and then it gets protonated, and then the positive charge on it makes it harder for it to seep back out. But even given that within cellular concentrations may be 10 times higher than circulating blood levels, it still seems that it's likely only having mild or weak effects on that NMDA blocker. So what else is it doing? One is that this is involved, it interacts with the aromatic L-amino acid decarboxylase enzyme, that's AAAD, and AAD is in the early steps important for making dopamine, for norepinephrine, and serotonin. So that's an enzyme that's important for the existence and levels of a number of neurotransmitters. Other things that the amantadine seems to do, it binds to something called sigma-1 receptors, and this is a system that has not been studied for a long time. So we don't understand fully what the best native endogenous receptors for sigma receptors are, but we know that if you bind to sigma-1 receptors like amantadine does, one, that boosts tyrosine hydroxylase activity. Tyrosine hydroxylase is one of the enzymes that's immediately precursor to making dopamine in the brain. So boosting that boosts the synthesis of dopamine. We know that sigma-1 receptor action modulates those NMDA blockers that are stimulating dopamine release. So another way to help boost dopamine release. We know that binding the sigma-1 receptors increases dopamine in living animals, including humans, in the striatum, in the part of the middle brain. We know that sigma-1 receptor action decreases dopamine reuptake, so more is left to be available. And actually boosting those sigma-1 receptors increases synaptogenesis and inhibits inflammation. That's probably more important for its help with those neurodegenerative diseases. Then I mentioned traumatic brain injury and dementia. Other things that the amantadine does, again, up to a stronger effect than its effect on glutamate and NMDA receptors is that it boosts what's called glial cell-derived neurotrophic factor. So that's a protein that produced by glial cells, the support cells of the brain, that decreases inflammation and increases nerve cell growth and connectivity. We also know that amantadine boosts certain phosphodiesterases, and these are enzymes that increase intracellular brain cell cyclic AMP and have anti-inflammatory effects. And actually, amantadine is a stronger blocker of certain nicotine receptors than it has an effect on NMDA receptors. That's a little bit strange because actually boosting nicotine receptors seems to be beneficial for ADHD. So the relevance of the nicotine receptor action is not clear at all. So the summary is there's lots of potential actions for how amantadine is working, and we don't know either for Parkinson's or ADHD or some of the others which of those actions may be most important, which are irrelevant, which are least important. If we have time, I may go into whether it's important or not to know why or how a drug works. But I'll jump into what the research so far has shown on amantadine for ADHD. So in 1980, there was a pilot study. It involved just 9 kids who were all between the ages of 10 to 13. They took 100 milligrams of amantadine twice a day. They stopped stimulants before they took it, and there seemed to be some substantial benefit for what we would call now ADHD symptoms. This is in 1980, they were defined as hyperactive children, but the conclusion of that study is that it was encouraging, that there did seem to be at least some effect. Some kids seemed to do as well on the amantadine as they did on the stimulant. Then it was almost 20 years before anyone did another study, and another tiny study, 2001, only 8 kids, and these kids had ADHD and other significant developmental delays or disabilities, marked impulse control and behavioral issues, but 4 of the 8 kids responded markedly improvement with amantadine. Then in sort of the more modern era, in 2007, there's a study out of Italy by Dr. Don Francesco. It was an open label study, so people knew what they were getting, and the doctors knew they were treating these kids. 24 kids were treated with clearly defined ADHD, and both teachers and parents rated how the kids responded. They were dosed up to 150 milligrams of amantadine a day. And in terms of looking at kids whose scores, again, this is on a parent-led rating score or teacher respondent rating score or both. So if their ADHD scores declined by at least a quarter, 25%, it was considered a positive response. And according to the parents, 58% of the parents thought their kids responded to the amantadine, and almost 50%, 46% of teachers saw that there was an improvement on amantadine. And the magnitude of the effect described by the investigators was less than, they did not do it again, a head-to-head study, but they felt it was a substantial, so bigger than placebo effects, but smaller than a stimulant effect kids usually get from ADHD. The next study was the first head-to-head comparison and blinded study, so conducted by Mohammadi in Iran in 2010. And they looked at 40 kids. They were on amantadine for 6 weeks, either doses of 100 or 150 milligrams a day, and that determined by their body weight, or again, this was randomly controlled, or they were on a dose of Ritalin methylphenidate that was either 20 or 30 milligrams, again, determined by body weight. So there was no adjustment of dose up or down in response to how the kid responded or not. And the the success of the study or the rating was both parent and teacher ADHD rating scales. And what they found is that there was absolutely no difference between the Amantadine group and the Ritalin group. They both showed a substantial and steady decline over the 6-week course of the study. There were more problems with decreased appetite and restlessness with Ritalin, and in all the studies so far mentioned, the Amantadine was fairly well tolerated. So these are all tiny little studies. Finally, in 2021, Morrow at Baylor University in Texas published a more substantial study. They looked at 291 kids, 251 of those who did have clearly diagnosed ADHD. Now, this is again an open sort of a chart review study where they looked at all the kids who were on Amantadine and saw what diagnoses they had and how they responded. So it's retrospectively looking at them. Again, people knew what they were taking, their doctors knew what they were taking. So certainly not a gold standard, but lots of informative information. That's redundant. Lots of good information, I would say. So one thing is that half of these kids, 48%, were also on a stimulant while they were on the Amantadine. The median dose, so that's the average dose in this study, and these are all kids, was 200 milligrams. So it's substantially higher than the previous studies. And the range was from 50 to 400 milligrams. They determined that about 2/3, so 65% of the kids on the Amantadine had what was determined to be a success, a good response to the Amantadine. Another 20% had minimal, so slight response, but not wowing anybody. And it was only 10-11% that showed no response and stopped taking the Amantadine because of that. And another 4% that had to stop because of side effects. I think a few cases were headaches, some were restlessness, and some were decreased weight, decreased appetite early on. That can happen with Amantadine. Again, it's less likely than it is with stimulants, and most reports suggest that that's a short-term, usually not an ongoing problem. So interestingly, of use is that they actually looked what types of symptoms in these kids with ADHD responded to the Amantadine. And in 82% of them, impulsivity decreased while on Amantadine. That was the best symptom cluster in terms of response. But 52% decreased irritability or anger. 51%, so about half the kids also had an improvement in focus. 29% had a decrease in aggression or outbursts, how you define that is different from irritability or anger. I think this is more the behavioral manifestations of anger, or maybe anger and impulsivity. And 21% had improvement on other thought processing, executive function, symptomatology. So again, a fairly broad range of ADHD symptomatology seems to respond. Furthermore, what they noticed was of kids who started, again, these are not a formal study, but who were initially on atomoxetine or guanfacine, almost half of those, 44%, either were able to completely stop that agent or reduce the dose substantially. On the other hand, only about 1 out of 5 people who were already taking stimulants when Amantadine was added on were able to stop or substantially reduce their stimulant. So it means that some were, but not a majority. And even more encouraging a reason to look into considering Amantadine is that of 88%, 87.5% of kids who had failed a previous trial of stimulants, 80% of them achieved treatment success or at least partial success when they tried Amantadine. And even more impressively, but similar, 90% of those who had tried guanfacine or atomoxetine and had either gotten no response or had gotten side effects were able to achieve treatment success with Amantadine. So Baylor is not the only child psychiatry a clinic that's using amantadine extensively and driven to distraction, Rady, and I'm blanking, last name begins with an H. Harvard psychiatrist, Hallowell and Rady discussed that there's at least a Harvard clinic that had experience with more than 400 kids with amantadine. I haven't found any results posted from their study yet. So this is being fairly widely used in academic centers, and probably from what we're seeing so far is reasonable to be trying more often in the child population. And given that everything we've looked at for kids with ADHD seems to have at least roughly comparable benefits in adults with ADHD, it certainly should be considered as an option there. I've only used it a handful of times, and the individuals that I've had it did not see much success. So personally, I haven't seen more. I'm happy if people write in and comment about what their results are or aren't. And I'll probably leave any discussion of why does it matter how a drug works to another topic. I think that's about all I want to say. So my take-home message, so I didn't address side effects too systematically. Again, most people report them pretty mild, even at this Baylor clinic where they were using substantially higher doses. Most people tolerated it well. Appetite suppression is one possible side effect, usually transient, short-lived. Very interestingly, in respect to some of our other studies and almost all the other drugs being used for ADHD, no increases in blood pressure are systematically noted. In fact, some people have decreased blood pressure. That also would suggest that if it's having much of a norepinephrine increased effect, it's probably purely within the brain and not much in the peripheral nervous system. Some people have some mild gastrointestinal issues, headaches have happened. The one recommendation I saw suggests in another paper that was promoting amantadine more broadly for ADHD, suggested people should start slowly on 25 milligrams and ramp up. The only pill size it's being made in right now is 100 milligram size. For these studies, the formal studies, most of the time they started directly at 100. So that may be overly cautious, particularly for adults. Again, the Parkinson's and other literature where this is being used, traumatic brain injury, where people are, we tend to be cautious and go slowly because brain is clearly physically damaged, or in Alzheimer's where it's degenerated. It seems to me reasonable and safe for most people could start at 100 and see what that effect is like, probably waiting several weeks before going to a higher level. So again, reassuringly, we're not seeing blood pressure problems, and given a moderate, but I'd say a fairly consistent body of literature showing it's decreasing brain inflammation and probably boosting factors that increase nerve cell growth and synaptogenesis, this is, none of those are indications that this is going to have a long-term detrimental effect on the brain. And many people with Parkinson's tends not to kill people quickly. Many people with Parkinson's persist, have their symptoms for a decade or more before they die. Many people have been on this drug for years and years at a time. So that's all I'm going to say. I can't see right now. I imagine, yes, there are a few questions already. I do not have my March schedule up. I have several ideas, but if you have more, I'm happy to hear them. But within the next few days, I'll post whatever the March schedule is like. And sometime in March, the rest of the country, US is going on daylight savings. They're off on Hawaii doesn't change, but I will switch my presentation an hour so that I'll be continuing on the same time on Tuesdays for most of the rest of the world. I know Europe also is out of sync with the US, but I'll let you figure that out. I'll try to be clear in my messages. So Hello, Dennis. Dennis asks, is it true that benzodiazepine and alcohol are the only substances that eradicate social anxiety? I'd say one is, so simple answer, absolutely no. I have worked with lots of people with the use of SSRIs. They don't always work, but they very often do. I don't know if there are specific studies looking at it because the SSRIs already have indications for other drugs and other conditions. But very clearly, and particularly in the setting of ADHD and social anxiety, I've had several individuals over the years who were happy with their ADHD action on a stimulant or another agent, but after months or years, were also aware that social anxiety, which hadn't been as prominent or they hadn't been able to pay as much attention to it because of their ADHD, they became more aware of it when the ADHD was well treated, and it was the addition of an SSRI. There's also, again, I don't know if there's formal studies looking at Buspar, but I've certainly seen Buspar be effective for social anxiety. So I don't have any evidence to suggest that social anxiety neurochemically is substantially different than generalized anxiety, or even as a distant cousin of full-blown panic, which again, all tend to respond to these serotonergic drugs. So Arlen asked, is Amantadine safe to take with bipolar 1? That's a great question. I did not come across any direct information at massive doses, well above 400 milligrams. There have been reports of psychosis. There have been reports of coma. So I don't have enough information to give it a complete clearance. What I can say is I didn't run across anything that raised huge bells with it. So I'll leave it at that. Mr. AKA 1996, hello again. So fluvoxamine is a potent sigma-1 receptor agonist. One of the reasons I chose to take it for anxiety, hoping it has neuroprotective effect in addition to the anxiolytic effect. So again, the sigma-1 receptor we're learning more about each month. And yes, from the available literature, it's likely that it may have neuroprotective long-term beneficial effects. And so Arlen asks again, next month, could you talk about ADHD meds that are safe to take with psychotic and or mood disorders? I'd say that as someone afflicted with both, I can put it on the schedule of things. Let me write it down because I don't get this list later. I do have a talk on amphetamine-induced psychosis. So I would say absolutely no amphetamine-based product should be used in anyone who has had a psychotic episode. There are some formal studies, small, and some practitioners who are comfortable using slow-release forms of Ritalin, methylphenidate, in someone who's had a history of psychosis. And in terms more generally of mood disorders, the stimulants have been used. There's extensive data going back decades, even before we had antidepressants. They were called antidepressants. The stimulants work for mood disorders. So if it's a mood disorder without a psychotic disorder, they are effective for depression. Again, as Arlen points out, that could be a whole topic. So I won't say more right now unless someone wants me to say more. So Zazushka asks, thank you for the videos. You're welcome, and I appreciate all the questions and the interest and the audience participation. Is it safe to take Concerta if I have short episodes of supraventricular tachycardia last for 5 seconds? They told me it is not a lethal rhythm. What I would say is, one is I'm not a cardiologist. Two is if you're really worried, consult with a cardiologist. Three is Usually supraventricular tachycardia is considered as you point out, a benign rhythm, that there are just some fast beats happening thrown in, and stimulants can certainly precipitate that or make them more common. So I would say, as a general statement, that it's not usually considered a contraindication, but again, if you have questions, certainly consult with the cardiologist. Again, there may be more complicated things going on. So, and I hope I'm not butchering your name, Tanner Sahin. Random question. I've recently been put on Cymbalta and heard it helps with ADHD. But I feel like I'm experiencing the opposite, extreme brain fog and lack of motivation. Is this possible? So yes, this is certainly possible. And people can have any response to any medication out there. Cymbalta, I use very commonly for ADHD. I've had lots of people with good effects, certainly not everybody. I use it far more than I use atomoxetine because it seems much more consistent and predictable in terms of its side effects. Lower motivation and brain fog, I mean, I would probably suggest experimenting with the dose before I give it up completely, but it sounds that the experience so far is bad enough to not want to persist. There certainly are some people on pure SSRIs and on SNRIs who get substantially different side effect profiles, particularly in terms of activation or decreased energy. That's something that can flip from one way to another within the first few weeks of taking it. But to me, brain fog would not be a particularly encouraging side effect or symptom to have with it that would make me want to persist or recommend persisting. So even though, again, overall, I like Cymbalta, which is duloxetine for ADHD. So Jennifer Parkinson asked, is Amantadine okay to take with armodafinil? And this is a sloppy parallel, but if we consider Wellbutrin maybe like a lighter version of a again, we know Amantadine has been used extensively in pediatric mental health clinics, pediatric ADHD clinics with a stimulant safely. So I would not have a reason to worry about Amantadine and Wellbutrin. It may, again, given that they both may be potentiating dopamine, it would be a reason to start cautiously or go more slowly, maybe than my original recommendation that anyone could just start on 100. I would go slowly. And I would think it's even more likely to be safe with armodafinil. Again, there's still non-agreement, and I have talks both on Wellbutrin and modafinil on this YouTube channel. Whether armodafinil's actions are largely via dopamine or whether they're more dependent on its action on orexin receptor systems is still, I would say, highly debated, but again, that would suggest it's likely to be okay, but do it cautiously. So Zazushka said the cardiologist told me I could continue taking Concerta, but I'm still concerned. I guess the only thing I can say further is asking you, what do you think would be reassuring to you to know, and or what are the specific worries or concerns you have? And again, a cardiologist may be the better person to discuss those with. Certainly there's a lot of people who have co-occurring anxiety and cardiac issues, or who have anxiety issues that create cardiac issues, or who have anxiety issues and focus on cardiac issues who don't have cardiac issues. So all of those are possible. But usually when there's fear, when there's anxiety, confronting it, looking at it, evaluating it, it may be reassuring to be on something like a Holter monitor, one of the monitors that's continually measuring your heart, for a week off of the Concerta and a week on it, to see really how big a difference this is, and whether you're just noticing more supraventricular tachycardia or whether you're really having more of it. And again, or talking to other people who have supraventricular tachycardia. There's online groups for almost everything. Probably you can find people there. So Jennifer's follow-up question, and which is a good one, is Amantadine effective in single doses or must it be taken daily? So all of the studies I've mentioned have only been looking at it, taking it regularly. Again, some of them were as short as a few weeks. The clinic, again, sort of chart review studies were on people who were taking it steadily for considerable periods of time. It seems, and specifically the only study that I can recall is the one that was a direct head-to-head comparison to Ritalin. And in there they looked at, I think, every 2 weeks over a 6-week study. Both the Ritalin and the Amantadine worked better. I mean, in terms of an ADHD response, so lower numbers, a better score, less ADHD symptoms. Both drugs over the course of 6 weeks were steadily declining. Again, there's only 3 or maybe 3-4 time points, and declining to the same extent. I would imagine that there are likely, if it's going to work for you, some immediate benefits. If you're hoping for the anti-inflammatory, synaptogenesis, sort of neuroprotective effects, my expectation would be those are more likely to accrue if you're taking it regularly. And again, I should be clear, what I'm saying now is largely speculation and not based on a lot of data. But there have been one or two comments that people should be cautious if they've been taking this a while for stopping abruptly, because there could be withdrawal symptoms, including neuroleptic malignant syndrome. I don't know if that's actually occurred or that's a speculative situation, or what doses people were on, if that has actually occurred. So thanks for all the questions. I'm glad you're here today. So Zazushka asks, does coaching work for ADHD? Good. So great question. And my somewhat flippant answer is yes, if you have a good coach and you're a good match for that coach. So, and I talk a little bit about this in a comment in a video about CBT and ADHD. What we know is people with ADHD need the right amount of structure, the right amount of support, reinforcement, and a good ADHD coach can do an excellent job of providing that. So again, not everyone's gotten benefits. ADHD coaches vary in their ability. There are some formal ADHD coach training programs and sort of certification. I think that Attitude magazine has an advertising section for coaches who have been vetted to some extent, or at least credentialed. I would not say that credentialing in itself and anywhere in medicine is always a direct proof that someone's competent or good or a good match for you, but it's at least an encouraging starting point. So stay healthy, stay happy, and I will see you next week. Sorry, one more Jennifer question. So Jennifer also mentioned that there have been anecdotal reports of fatigue and sleepiness. And she asks, is this a paradoxical immune response in some people or some neurobiological property that would lead to this? So I would say nobody knows that I'm aware of, and particularly given that one of the areas that this is being researched in is a neuroimmune condition, which is MS, and it's actually been specifically used there to treat fatigue. But again, almost anyone's allowed to have any response to any medication out there is my somewhat flippant response. So ACBC seemed to be commenting on maybe Arlen's comment that he has ADHD and bipolar and he's taking Ritalin and he feels he's I'm assuming it's a he, I shouldn't assume that. They is a better human being for it. So that's all. Stay healthy, stay happy. I will be back next week. Thanks for the questions. Thanks for the attention. And like this and recommend the channel to others if you think it's been helpful.